Continuing with the testimony. Doctor, you're still under oath.
Thank you, Your Honor.
Ms. Grubb.
Dr. Schweiger, we're now going to turn to the matters regarding James Timmons. Did you review Mr. Timmons' medical records?
Yes, I set out to review him in the totality of the medical records that were provided prior to authoring my reports.
Thank you. Were you also provided with a coroner's report after reviewing the medical records?
Yes, I was, after.
Were you provided with the coroner's report after you wrote your report in this case?
Correct. I did not receive the coroner's report until after I wrote my report.
May I approach your Honor?
You may.
Handing the witness State's Exhibit 18-0. What is that, Doctor?
This is the coroner's report from the Franklin County Coroner's Office investigating the death of James N. Timmons on October 24th, 2018.
Thank you. Did you review it?
I did, yes, ma'am.
What did you find upon your review in that report?
So the key findings in the coroner's office report included, number one, that there had been recent utilization of cocaine and fentanyl in the patient, that he had severe underlying pulmonary edema on the autopsy, that there were both recent and remote needle tracks that indicated the portal of entry for his drug usage, and that the associated findings that were described that by the autopsy was systemic shock involving the whole body, acute renal failure, meaning kidney injury or kidney failure. He was status post-surgery on the left lower extremity, after which they had opened up the leg to release the pressures in the leg, secondary to compartment syndrome. The toxicology, which was the blood drawn before death ante-mortem, it indicated that there were numerous substances detected. They found the metabolite of nicotine in his body, indicating he was a smoker. They found the drug ketamine, which is a medication administered and also at times abused. They found norketamine, which is the metabolite of ketamine. They did not find cocaine in the blood acutely, but it did appear that there was some metabolites of cocaine that he had previously taken. There was no detection of the acute concentration of marijuana, which is THC, but there were some metabolites present in the blood. And then going down, it did show the presence of fentanyl in his blood, the nicotine and nicotine metabolites that I mentioned, and then the multiple metabolites of the ketamine. And then on the final page of the toxicology, it revealed positive for cocaine and benzoyl ecogene and methyl ecogene, which are metabolites. So ultimately, the pathologist in coroner's office concluded that the cause of his death was recent cocaine and fentanyl abuse, and they ruled the manner of death an accident.
Thank you. Was the blood tested ante-mortem or post-mortem?
The coroner's office indicated that the sample was ante-mortem and that it had been obtained on October 22nd, 2018 at 21:47 military time, so essentially 9:47 p.m. on October 22nd, 2018.
Thank you.
So prior to his death.
When was he admitted to the hospital?
Mr. Timmons had been admitted to Mount Carmel West on October 22nd of 2018.
Thank you. And what were his complaints upon admission?
So Mr. Simmons had been, as is indicated here in the notation, he had been found down at home, presumptively by a roommate, without really a recollection of what had occurred overnight. He was, however, at that time discovered with needles nearby, so the presumption was that he had been abusing illicit substances, probably through injection, and had then lost consciousness for some period of time and had been essentially not moving. So what is indicated here when he presented, first of all, he was very cold. You can see the word hypothermic means that his core temperature was very low. Also, he had little blood sugar in his body. Normal blood sugar is between 70 and 110, and he was at 29 in his blood. He had received multiple doses of Narcan as part of the resuscitation, and also dextrose, which is sugar. The vital signs that are demonstrated here confirm his hypothermia. They also confirm a very low systolic blood pressure. Normal would be 120/80. His was 47. But more importantly, they found that he had what is known as rhabdomyolysis, and that means that he had significant muscle breakdown, likely because he was laying in one place for too long from having passed out from the drugs. And here we see leukocytosis, means markedly elevated white blood cell count, but life-threatening was the serum potassium, which normally is between 3.5 and 5. His was essentially double that at 9.1. And that occurs because when muscle dies and breaks down, it releases potassium from inside the cells into the blood, and that can be poisonous to the heart. His buffer, the sodium bicarbonate, which is normally 22 to 26, was cut by more than half. It was 9. And the difference in his anion calculation, which normally is 6 to 10 or thereabouts, had essentially more than tripled to 33. Very frequently, when a patient has severe rhabdomyolysis, the muscle protein will poison the kidney. And that's what we see here. His creatinine, which for his age should have been less than 1, was at 3.47. So he was presenting an acute renal failure. And then his liver also had been injured. So that's why I wrote increased liver function test. And CK is that protein in the muscle. That's creatinine kinase. Normally should be less than 100. His was greater than 5,000. And then he had lactic acidosis, so that since he wasn't getting enough sugar in his blood, he was going through that process of trying to create energy without sugar, and that's why he was making lactate. And then the initial UDS, which stands for urine drug screen, which was done because of this description, tested positive for cocaine and for metabolites of marijuana. So they listed here that he was immediately given a consult by the kidney doctor, the nephrology, because those numbers were so high and the potassium so high that it could easily stop his heart. So they were getting urgent dialysis in, and they were going to transfer him to the ICU in order to achieve that.
When did he go to the ICU?
So he went to the ICU relatively rapidly because he needed to have vascular access, meaning he needed an ICU doctor to be able to gain access into the big veins of the body in order to perform the dialysis. Without that, you couldn't do it urgently. So they tried to transfer him as rapidly as possible to the ICU. Unfortunately, during that process, before they could really purify his blood, he suffered what's described in his record as a sinusoidal code blue. And what sinusoidal means is that on the EKG, it has the waves of the ocean. So rather than the normal spikes you see on an EKG, when you have very high potassium, potassium poisons the heart. We should have low potassium in the blood, but but high in the cells. When it gets in the blood, it interferes with the electrical system of the heart, and you start to see these very aberrant waves, again, that almost look like those waves on the ocean. So that resulted in him rapidly deteriorating.
Thank you. Did he code again?
Yes. He had essentially the first, and then he was resuscitated, and then he had another essentially code related to not only the potassium, but likely the worsening of the acidosis due to his kidney failure and the shock, because as the body makes more acid, it actually pushes more potassium out of the other cells, and that just worsened his underlying condition.
Thank you. How did his ICU course progress?
So again, initially there was an evaluation that was undertaken to assess his status, and I believe he was seen by Dr. David Ralston, who is also one of the critical care doctors at Mount Carmel West, who conducted the assessment of the patient. There were really two life-threatening issues in Mr. Timmons. Number one, I've already discussed the high potassium and the cardiac arrest. The second was concern that he had laid in one position so long that he developed what's known as compartment syndrome, that the muscle within his leg was essentially dying. And when that happens, it swells from the inside out. So it's almost like you may have seen if you cook a hot dog in a microwave and it just spreads so long until eventually the skin of the hot dog ruptures. If that muscle gets so swollen, it continues to swell, and eventually that will cut off the arterial system, so they'll lose sensation. It'll cut off the neurological sensation, so they won't have pulses, they won't have pain, the leg will be blanched because you don't essentially have perfusion, and that will cause further muscle breakdown. So there was a stat consult placed to orthopedic surgery, Dr. Nicholas Wilson and Dr. Stephen Gaines, that is described on the bottom of page 8 and the top of page 9, in which they were evaluating him for this compartment syndrome, because what an orthopedic surgeon will do is usually take the patient to the operating room and they'll open the fascial compartments up of the leg surgically, so that will allow expansion of the muscle, and that may potentially save the muscle inside of it. It's not always able. If the muscle's already dead, you can't bring it back, but it will usually at least give the patient the best chance. So that was done, and they did do a lower extremity fasciotomy. And I described that on the top of page 10, where, again, they talk about emergency need for a 4-compartment fasciotomy. There's 4 compartments to the lower leg, and they felt it was indicated to open all 4 up.
Thank you. Doctor, what is your evaluation of the salvageability of Mr. Timmons?
Once again, Mr. Timmons was seriously ill. He was life-threatening ill, and he absolutely needed to come to the ICU. So there's no question that the doctors in the emergency room did the right thing by getting him to the ICU. These are 2 or more life-threatening conditions. At the same time, he did present to the hospital awake and alert, so that he was certainly not dead on arrival when he came there. So this is the type of patient that I've described earlier that needs a period of time to evaluate. First of all, to see whether the lower extremity fasciotomy, opening the leg up, can salvage muscle of the leg, or whether a part of the leg, whether that be the foot or below the knee, needs needs to be amputated in order to save the patient's life. Also, given the fact that he had not one but two cardiac arrests, but that there was a clear mechanism for the cardiac arrest being the elevated potassium, he would fall into that category that he may regain consciousness, he may be able to at least survive this event, albeit with major support. He needed dialysis, he likely would need ongoing fluid and pressor support, but I would have counseled his family to give him 48 to 72 hours to see what his salvageability was, and again, allow his body to declare to me as the physician and to the team how severe his end organ status was.
Thank you. What medications did he receive?
May I look at the MARS real quickly? Thank you. So when he first arrived at Mount Carmel West, the treatment team initiated what's known as the Hyperkalemia Protocol. And in doing that, what you do is you inject the patient with insulin, because even in the non-diabetic, if you give the patient insulin, it pushes the potassium back into the cells. It's kind of a side effect of insulin. So we can see on the first page of the MARS that he was given an insulin sliding scale. Also, because of this tremendous swelling in the lower extremity, he was administered heparin, which is a blood thinner. Because the swelling of the leg is painful, particularly if there's viable muscle there, you literally feel like a boa constrictor is wrapping around your leg. So he did report some initial pain, so they gave him at 11:58. There was an order for 100 micrograms of fentanyl that had been ordered. There also was an order, I think a little later after midnight, for 2 milligrams of Versed to be given. And then he was essentially assigned later on, I think, administration of sodium bicarbonate. And essentially that's an alkalinizing or neutralizing substance. Bicarbonate will bind to acid and will help take that out of the system and then be excreted in the kidney, or in this case, it would be washed out in the dialysis. And then we see additional indications for small amounts of fentanyl. At 5 in the morning, they gave him 100 micrograms of fentanyl. He also had another order for 2 milligrams of Versed. Then on the 4th page of the MARS, we see that he was ordered by Dr. Husel, and this was appropriate, a drug called calcium chloride. When the potassium is high and it's going to poison the heart, the antidote, besides trying to push the potassium into the cells with insulin, is to give calcium chloride, which will stable the heart. So that was ordered at 6:54 in the morning and was received. Also, he was at risk for a bleeding ulcer because of the stress and the drug abuse, so he received Protonics as part of that therapy. He was given some topical medication because of the leg. And then we see the orders placed for more calcium. They started him on antibiotics because once his leg was opened up, he would have been vulnerable, because you're basically slashing the whole leg open. This is not a minor incision, and you're not suturing it shut. You're just leaving it open until the swelling is done. So he received cefepime at 11 a.m. on the 23rd.
Doctor,
Yes.
Can we turn to the administration of any pain medication through virtue of surgical procedure or infusion?
Yes, certainly. So we certainly see that he did receive the medication fentanyl by the certified registered nurse anesthetist. In this case, it was Patrick Turner, who worked in the OR as the CRNA, and that was under the supervision of Dr., and I apologize, I'm mispronouncing, but Chiroma Milla, who was the anesthesiologist, and we see that he received from that team incremental fractionated fentanyl administration during the fasciotomy.
Can we stop right there?
Sure.
And may I look at the page that you're...
Yes, ma'am.
note that there's some numbers there, 14321, and then a microgram number. Can you explain what those numbers are?
Yes, so what that indicates is that the anesthesia team was providing this pain medication to Mr. Timmons on an infusion. And what is indicated here on the MARS, again, there'd be more detailed information on the anesthesia record, but the MARS is kind of the summary. So what we see is that the patient received, according to this documentation, 14,321.249 micrograms that were dissolved in a total infusion of 286.42 mLs.
Was that entire amount infused? Can we tell?
No, from this you can't tell. What we can see is the constitution of the drip that was put forth, and then one would study the anesthesia record to assess how much of that infusion was given to the patient.
Okay. And how long was that surgery, if you know?
My recollection, and it's been a little while since I looked at the surgical and operative, but that it was approximately 2 hours.
Okay. And would it be reasonable to receive that amount of fentanyl in 2 hours?
No.
Turning to the infusion record, continuous infusion record, can you talk a little bit about whatever continuous infusions he may have been receiving?
I think there may be a few missing pages. Because I have the bottom page, but I think there was. Do I have it all? Okay, well then I have it all. So that being the case, the continuous infusion that's documented was the drug dopamine, which is a mixed vasopressor and inotrope that is meant both to increase the patient's blood pressure but also increase the squeeze of the patient's heart.
Was there any other pain medication applied? Continuous infusion.
That's what I'm saying. I think there may be another sheet because I don't see it listed here. He did. As I said, there were some additional entries regarding the fentanyl that was administered earlier, but I don't see on this sheet any listing specifically of continuous infusion.
Did you also review the pain scoring?
Yes, ma'am, I did.
Presenting you the pain scoring for Mr. Timmons.
Thank you.
Have you reviewed?
I have, yes, ma'am.
What does the pain scoring inform us of?
So in looking at the pain scores that are documented, the initial pain score when he entered was a 0, but then shortly thereafter, and I believe my memory is it was at 6 p.m. and at 8 p.m., he did report a 10, which is consistent with his presentation because, again, he was having this compartment syndrome. He was regaining consciousness after being down for an unknown period of time. But after that entry of the 10, then all of the remainder pain scores were 0.
What happened to this gentleman after the surgery?
So after the surgery, he again showed some continued deterioration. There was concerns about shock liver, that the process that had been unfolding, coupled with the change that had gone on that had resulted in the dying muscle, had impacted the perfusion to the liver, so that was concern. There was obviously the concern about the impact of the medications, the drugs that he had ingested or had injected at that particular time. There was the consultation placed by the kidney doctor that agreed. It was in the evening of October 22nd where they had indicated that they were going to obtain and start the dialysis. There was also indication that they wanted to obtain imaging of Mr. Timmons' heart with the echocardiogram because, again, since he had been injecting medications, he was at high risk for endocarditis of the valves. So they wanted to get blood cultures. They wanted to get the echo to rule out vegetations or endocarditis. They also were going to order blood and urine cultures. And again, Dr. Ralston from Critical Care, and this is on the bottom of page 6 on my report, all the way through the bottom of page 8, wrote a detailed description of his findings during the initial assessment, and he also on page 8 discussed his update that he gave Dr. Husel. So he saw the patient initially and then gave a verbal report to Dr. Husel, particularly regarding the need for the dialysis access, because Dr. Ralston hadn't been able to put in the catheters and was going to defer that to Dr. Husel.
What lab values was he showing as he progressed?
So he was showing worsening of the acidosis. He was showing certainly signs that the kidney function had been impaired by the impact of the injury. We see that even after the arrest and after the dialysis, and this is on page 13 of the note, that he had a serum potassium. It had come down from 9.1 to 6, so it was progressing in the right direction, but that was still elevated. His carbon dioxide or bicarbonate was still low at 17, but had improved from 9 to 17. His kidney function with the dialysis did show some minimal improvement. He had a marked increase in his white blood cell count at 21.6. And then he also showed an upward trend in his hemoglobin and hematocrit, but that was probably related to how dehydrated the patient was upon arrival.
Thank you. At some point, did this gentleman's DNR status change?
It did, yes. So after, as I mentioned, Dr. Husel did place the dialysis catheters into Mr. Timmons. In fact, there was an arterial line placed in the wrist. There was a central line placed, and the dialysis catheter. That was all done on the evening of the 22nd. As we already discussed, the patient had surgery. But then in the early morning hours of October 24th, there appeared to be an abrupt change in the direction of the therapy, and the order for full resuscitation was canceled, and an order for the DNR comfort care measures was placed.
Was there then a move towards extubation?
Correct. After the DNR order was placed, and that was timed at 2:37 in the morning of October 24th, there was thereafter an order placed at or around 3 a.m. for 1,000 micrograms of fentanyl. additionally, at that time, there was an order placed for 10 milligrams of Versed. And then 5 minutes later, there was an order placed for at 3:05. So the first two orders were at 3 a.m. 5 minutes later at 3:05, there was an order that I found in the chart placed for 10 milligrams of Dilaudid, and then an order placed at 3:05 for 20 milligrams of Versed underneath that. And then 18 minutes later at 3:23, there was one last order for 10 milligrams of Versed.
Okay. So do we know then how much in the way of opioids were administered?
Yes, in looking at the MARS, it appeared that the patient did in fact receive 1,000 micrograms of fentanyl, and then received, subsequent to that, received 10 milligrams of Dilaudid.
What about the Versed?
The Versed, let me just find it here. So there's confirmation in action details that the first order of 10 milligrams of Versed were administered. And then additionally, it appears that the second dose of 10 milligrams of Versed were received.
How much time was elapsed in between the two opioids?
So between the two opioids, the orders were apparently given 5 minutes apart, and according to the documentation of the action details, which is the action of the nurse following the orders, they were essentially documented to have been given at the same time, both administered at 3:24 a.m.
And what is the equivalent dose in fentanyl to this amount of hydromorphone or Dilaudid?
So in terms of equivalency, the administration of 10 milligrams of Dilaudid is equal to an additional 1,000 micrograms of fentanyl. So it would be essentially equal to giving the patient 2,000 micrograms of fentanyl.
Thank you.
We got to make sure they're not mixed in.
Yeah, sorry. Okay, so these are all the continuous infusions. All right, we've got those pages. Doctor, I'm handing you a stack of documents. Would you please tell us what those are?
So this stack of documents is what I recall, that there are multiple pages in Mr. Timmons' records that chronicle the continuous infusions he received during his essentially 2+ day tenure at Mount Carmel West. It lists the various medications that were being continually infused into the patient.
Thank you. Can we address our attention to the fentanyl?
So I find multiple entries regarding fentanyl infusion in the patient.
Okay, thank you. And is it easy to calculate how much he received during his hospitalization?
It's not easy because there was alterations in the rate of infusion to the patient. So for example, the first entry that I see in the medical record includes a fentanyl infusion that was ordered at 25 micrograms per minute. And then there's an action detail that talks about an infusion of 30 mLs per hour. And again, it lists the ingredients on the top of that infusion. Then later on in the chart, there is a change on October 23rd at 8:12 in the morning. There appears to have been a change, at least indicated here under the ingredients section, where it's identified as a rate change. But again, this electronic medical record can be somewhat confusing in terms of what is indicated, because it lists, again, with a code, the FENT50IT, and then 300 mics per hour. But then below that, it still is listing the rate at 30 mLs per hour, which was actually, I believe, the rate that the earlier rate was placed. So there are some confusing entries in the MARS.
Would it be expected that this patient would have pain?
Yes, certainly a patient that had compartment syndrome with injured and potentially damaged muscle would likely have pain, so that is true. And then the fact that he underwent surgery with the fasciotomy would also be consistent with the patient who would have some element of pain.
Do you find these infusions to be appropriate?
Yes, even with slight editorial confusion in terms of some of the rates, certainly the actual infusion rates that were indicated here appear appropriate for a patient who presented with Mr. Timmons' problems and the need for going to the operating room.
Thank you. Do you feel that the discussion of his DNR-CC was appropriate?
Yes, he presented with major medical problems and he had multi-system organ dysfunction. So I think a realistic discussion with his next of kin regarding his outcome was appropriate, and certainly entering a DNR order at some point was certainly reasonable.
Thank you. Do you believe the timing of the palliative extubation was appropriate?
In my professional medical opinion, the timing of the palliative extubation was not appropriate, given that he had undergone surgical exploration and fasciotomy, that he was receiving support for his underlying organ function, that although there were abnormalities in the labs, despite the fact there was dialysis, they were in fact improving, and that he needed ample time to declare the severity of the neurological injury he may or may not have suffered during those 2 code blues. It appeared too hasty to just progress immediately to withdrawal of support and a terminal extubation.
Thank you. Based upon his overall medical condition, his history as a drug abuser, and the toxicology report along with the infusions that he received in the hospital, what is your opinion as far as the appropriateness of the dosing offered and administered to this patient at the point of his extubation?
Within a reasonable degree of medical certainty, the doses that were provided were in excess of what the patient warranted based on his pain scores that had, after his code, been 0, and the fact that, again, he remained comatose and was not demonstrating either acute anxiety, agitation, or pain. Certainly, based upon all the information available, Mr. Timmons would have had a requirement for some increase in his analgesic requirement. So certainly, if one were going to order fentanyl for terminal extubation, I think a dose in the range of 300 to 400 micrograms would have been indicated based upon his history of drug consumption. In fact, he had been apparently exposed to various various illicit drugs over time, and he had been exposed to fentanyl while in the hospital. But certainly to order the 1,000 micrograms of fentanyl combined with the Dilaudid did not seem to be indicated based upon his clinical condition in the ICU or the documented pain scores.
Thank you. Do you see any legitimate medical reason for the dosage administered to this patient at point of extubation?
No, at the point of extubation, I do not see medical justification for administering 1,000 micrograms of fentanyl combined with the 10 milligrams of Dilaudid, which in essence equaled 2,000 micrograms of fentanyl. As I mentioned, it was reasonable to expect that Mr. Timmons would require more than the average patient, but the appropriate step would have been to administer, as I said, 300 to 400 micrograms of fentanyl is a large dose. And so for his history of drug abuse and his presentation, that should have been adequate to control his pain, with then subsequent orders as need be to allow the nurses to titrate more if, in fact, he demonstrated any pain or discomfort following the decision to terminally extubate and remove life support.
In your opinion, did the dosing given here, the 1,000 micrograms of fentanyl plus the 10 of Dilaudid plus the midazolam, hasten and or cause his death?
Yes, in my professional opinion, within a reasonable degree of medical certainty, given the timing of the administration of the fentanyl, the Versed, and then as well the Dilaudid, it does appear that this did accelerate, thus hasten, the demise of Mr. Timmons following the removal of the endotracheal tube and withdrawal of support. And that's particularly true given the fact that he had experienced the renal dysfunction, he had experienced the shock liver as a result of the drug overdose and the concomitant findings, that there was really no period of equilibration in his body to give the fentanyl that was even administered time to work, let alone see what the effects would have been before moving to give Dilaudid, which was a second opioid that would likely have exacerbated the respiratory compromise induced by the fentanyl.
Thank you. In your opinion, does the doctrine of double effect have application in this case?
No, in studying this case, I essentially concluded that this case, again, does not demonstrate or document an appropriate application of the doctrine of double effect. As I've mentioned many times, Mr. Timmons was very sick, and he had a very questionable prognosis based on all that has been discussed. But again, one has to use proportionality. There was no indication to administer both fentanyl and Dilaudid to this patient at the time of the terminal extubation. Administering one of those and then assessing the effect would have provided moderation and prudence. Similarly, the comment about the Versed, which was given as a sedative in this case, and given the fact that he had remained in coma and was not responsive and not reporting pain, it would not, this intervention would not be consistent with the doctrine of double effect.
Thank you. What actions or lack of actions taken by Dr. Husel speak to his intent in this matter?
Well, first, again, given the complexity of his psychosocial presentation, Mr. Timmons definitely required a palliative care consult. Again, not only was he found down without any really reliable history, so the circumstances were certainly questionable, but again, his life positions required really a careful assessment by palliative care and social work as to what would have been likely outcome should he survive this hospitalization moving forward. Again, also, since there was really a multidisciplinary approach in terms of his initial hospital stay, including not only the kidney doctor for dialysis, but orthopedic surgery. There should have included those services in a discussion as to whether his limb was salvageable and whether his life was salvageable, or if in fact all of these things put together would have hinted at a terminal status. So the failure to consult and wait for palliative care, the failure to organize a multidisciplinary conference to assess the situation, and to proceed with terminal extubation and withdrawal of support certainly implies intent, in this case, to hasten the patient's ultimate death. Additionally, the decision to give 2 powerful opioid medications in combination with the Versed and not to allow a period of time between the administrations to adequately assess the effects of the opioid and the Versed also speaks to the intent that the goal was to hasten the patient's respiratory compromise and ultimately apnea, which would lead to the patient's death, given his tenuous underlying kidney, liver, and bodily function.
Thank you. Okay. Let's turn now to Sandra Castle.
May I just give you this back to you so you can keep it?
Oh, sure. Thank you. Okay. Doctor, did you review the medical records for Sandra Castle?
Yes, ma'am. I did review the medical records of Sandra Castle while a patient at Mount Carmel West.
And did you write a report in her case?
After I reviewed her medical records, I did in fact write a report.
Okay. What was this lady's presenting problem?
So Ms. Castle's presenting problem centered around her heart. She had a witnessed cardiac arrest at home. Her son initially called 911 to summon EMS to the house, and then immediately proceeded to start CPR on the patient. So this again categorized as a witnessed out-of-hospital cardiac arrest. When EMS arrived, they found on the EKG monitor that she was in ventricular fibrillation and that she required several shocks to try to restart her heart, but they were unsuccessful. What it did do was it converted her ventricular fibrillation to tachycardia, ventricular tachycardia. Thus, they gave the administration of amiodarone, 300 milligrams, shocked her again, and this time they were able to return a pulse. Since she was an out-of-hospital arrest that had been witnessed, and since she had ventricular fibrillation, it was decided that she would be an excellent candidate for therapeutic hypothermia, meaning that the team would cool her in order to preserve brain and neurological function. So she was supported on a blood thinning drip, the heparin, and also put on a vasopressor drip, the Levophed. And as may often happen in patients who have cardiac arrest and develop anoxic encephalopathy of the brain, she started manifesting facial twitches that concern them. This can be described either as abnormal seizure activity, or more appropriately, it's referred to as myoclonic twitching, because it's not a true seizure on the EEG, it's more a result of the temporary injury to the brain. And so as a result of that, cardiology then investigated her pacemaker, which had been implanted in her previously, and they found that she had had ventricular tachycardia previous to the arrest. So that was likely the reason that she had this event. And then she, of course, was admitted to the ICU.
Thank you. In your review of this lady's medical history and records, did you feel that she had a salvageability?
So neurology was consulted, a Dr. Alexander, who did raise the concern about anoxic encephalopathy of the patient, which would be injury to the brain due to lack of oxygen during the code. Again, there were discussions with the son about this, and in fact, Dr. Adam Mahoney, one of the intensivists, had entered in his note that there had been a discussion about a palliative withdrawal of the patient, and an order was placed for a palliative care consult as well as a DNR comfort care prior to the patient being extubated.
Thank you. What happened then?
So at that point, because the patient had manifested essentially a abnormal Glasgow Coma scale of 3, it was basically determined that she had been comatose during that period of time, and as a result of some of the facial movements and twitching, she had been administered on November 13th, 2018, various medications. She had gotten small amounts of morphine. She had also gotten Ativan. The patient had been extubated on the afternoon of November 13th at around 4:52. And then I noted entries for the Ativan and morphine at 6:33, at 7:03, at 7:33. And then further on, again, later on, there was the nursing transfer between the day shift and the night shift that addressed the decision for the extubation. And then later that night, there were additional doses of Ativan and morphine given to the patient. At or around then the 10:57 mark, it appears that Dr. Husel was called, and then he placed an order for 1,000 micrograms of fentanyl in the patient, and then that was subsequently administered along with 10 milligrams of Versed.
So when this condensed history says that she was extubated at 16:42, that is a day shift time, correct?
Correct. In the ICU, the standard time is 7 a.m. in the morning, or 0700, through 7 p.m., which is 1900 hours. So as is indicated here in the medical record, 1642 military time means 4:42 in the afternoon, so this would be the day shift.
Do you believe that Dr. Husel ordered that extubation?
No, I don't believe Dr. Husel was working the night shift, so this extubation occurred, I believe, at the discretion of the physicians that were seeing her on the day shift, and they had ultimately agreed that there would be this extubation.
Thank you. Did you review her pain scores?
I did, yes.
And what did they reveal?
So there were variable entries, and may I just review them quickly before I comment on them? Thank you. So a review of the pain scores revealed that after she had first arrived, there was one pain score of 10. Thereafter, her pain score went to 0 and was consistently 0 on November the 10th, November the 11th, the November the 12th, and then the first indication of an uptick in the pain was shortly after midnight on November 13th, where an 8 was assigned. And then after that, there was no documentation of the pain score until 8:30 in the morning, when Ms. Castle was once again given a 0, and then at around the time of extubation at 16:34, she was again given an 8, and then thereafter variable, there was a 9, an 8, a 9, and a 9.
Can I just get a report here in the notebook?
The what?
The report that you have in the notebook on this patient?
Report. This,
Yes, yes. Thank you. Just want to make sure that we don't want to issue it in your side. One moment, Your Honor, please. Sorry, and just want to make sure that it wasn't changed for now.
no, there's a problem with that. At some point, was there a discussion of her DNR?
Yes, prior to the decision to extubate the patient, there was a discussion reflected in her medical record, and the decision was made to proceed with a DNR status.
Thank you. And do you feel that that was appropriate?
Yes, given...
I'm sorry, is it your opinion that that was appropriate?
Yes, it is my opinion that based on both her advanced age and the sequence of events that are described in the medical record, that certainly it was reasonable to assign, after discussion with the next of kin, a DNR status in the event that she would succumb from this event. Further resuscitation would unlikely have provided any benefit to Mrs. Castle.
Thank you. Do you believe that the palliative extubation in this case was appropriate?
Yes, given the totality of the findings in the medical record, coupled with her advanced age and the underlying disease states she had, the decision to palliative extubate the patient at 4:42 was medically justifiable.
What is your opinion with respect to the dosing of medications attendant to the extubation and thereafter?
So the initial decision at or around the time of extubation to provide the patient with 100 micrograms of fentanyl was certainly within a range that could be medically justified. Thereafter, after she was extubated, as I mentioned, she received morphine and Ativan, and that certainly was also consistent with compassionate care. The doses were on the lower side. She was ordered 4 of morphine and 2 of Ativan. There was then, exactly as I discussed, incremental fractionated increase. It went from 4 of morphine. Later on, they then increased it to 10 of morphine. That's still within a range that would be considered medically justifiable to avoid any experience of pain. But then when we get to the evening hours, the order placed by Dr. Husel for the fentanyl combined with the Versed, that would not appear to be medically justified.
Was there any legitimate medical reason for this dose of fentanyl?
No, ma'am. At that point in the evening, Ms. Castle had successfully survived the terminal extubation. She was being provided both pain medication and appropriate sedation in the event that she was experiencing any discomfort or any agitation related to the terminal extubation. But from that period of 4:30 when she was about to be extubated up through the time that the order was placed for the fentanyl and the Versed, I couldn't find any significant documentation that the patient was in any way demonstrating abnormal physiologic responses that would justify such a rapid escalation in the doses of fentanyl and Versed that evening.
What purpose could this dosing serve at this level?
Well, given that there was no medical justification for 1,000 micrograms of fentanyl or 10 milligrams of Versed, and that she was elderly, more likely than not, within a reasonable degree of medical certainty, it would rapidly penetrate the brainstem, reducing her ability to spontaneously breathe from that point forward. It would also make her insensitive to the rise in carbon dioxide within her body, which would further blunt her response to breathing once the carbon dioxide elevated. So in terms of the intent, it would appear that the intent of administering fentanyl and Versed was to cause apnea, which would then hasten the patient's death rather than allow a natural death to occur, as was initially ordered by the palliative extubation and the 6 or so hours where she breathed on her own.
Do you believe that this dosage, in your opinion, did the dosing of the fentanyl and Versed cause the death of this woman?
Yes, within a reasonable degree of medical probability, the administration of 1,000 mics of fentanyl coupled with the 10 milligrams of Versed hastened Mrs. Castle's death on the evening of November 13th. Certainly, I agree with the doctors that were caring for her that she was entering a terminal phase, and certainly allowing her to progress to a natural death was certainly justifiable, but the acceleration of the death by the fentanyl and Versed does appear to have been the causative factor as to when she actually died at 11:20, which was, in essence, a little more than 20 minutes after those two orders were placed.
Thank you. Doctor, I'm approaching with State's Exhibit 32N, which is your report. Could you please address in the report your opinion as far as who extubated this patient?
So on page 20, in the verbiage, it appears that I attribute the extubation of Mrs. Castle to Dr. Husel, and that would be inappropriate. And looking further at the chart, the extubation actually occurred prior to his arrival that evening for the case.
Thank you. Anything else you want to address in the report?
So on page 17, the phrase, additionally, Dr. Husel ordered medication to induce a terminal extubation is incorrect. Obviously, since he didn't participate in the terminal extubation, that sentence would have to be retracted because he did not participate in the actual decision for extubation.
Thank you, John. your opinion, does the doctrine of double effect apply in this case?
No. After a careful review of Ms. Castle's medical records, it again does not support the application of the doctrine of double effect. Although I certainly do support the decision of the treating physicians to determine that she was terminal and to allow natural death to occur given her advanced stage and underlying medical conditions, I cannot justify the doctrine of double effect in terms of administering the fentanyl, 1,000 micrograms, and the Versed at the time they were given, since at that point, again, she had been breathing on her own. She clearly was trending towards a natural death, so there appears to be no moderation or proportionality justifying the decision to accelerate her death late in the evening.
Thank you. What actions or lack of actions taken by Dr. Husel speak to his intent in this matter?
So in terms of lack of actions, obviously the decision for terminal extubation had already been made. So I have no criticism of Dr. Husel's involvement because he was not involved in that phase of the care. Rather, the criticism revolves around the orders had already been placed, and there were reasonable orders provided for the care of Ms. Castle. The administration of the incremental doses of morphine, the availability and administration of the Ativan certainly would have provided an 80-year-old with adequate analgesia as well as sedation during the dying process. Again, there really wasn't an indication that Ms. Castle was in any way suffering from acute pain prior to the progression to the palliative care. And although, again, she did have CPR and one could invoke that there could be some broken ribs, again, the morphine should have been adequate to control that. So in terms of this case, the criticism in regards to what supports the indication of intention is the decision to transition from morphine to fentanyl, and then the excessive dose of fentanyl in combination with Versed after the patient had already received multiple doses of morphine and multiple doses of Ativan, which in the elderly, more likely than not, would result in apnea, would result in blunting of the brainstem's response to both low oxygen, high CO2, and thus cause the patient to stop breathing and eventually for her heart to stop.
Thank you, Doctor. I'd like to turn now to the matter involving Rebecca Walls. Did you review the medical records of Rebecca Walls?
Yes, I did review the medical record folder electronically of Rebecca Walls.
And what was her presenting problem?
Mrs. Walls had a history of essentially poorly controlled type 2 diabetes. As a result of that, and perhaps some element of blood pressure issues, she did develop chronic kidney disease stage 4. She also had abnormal peripheral neuropathy. On November 13th, she started to experience nausea, and she suffered from what was described as non-coffee ground vomiting without any specific abdominal discomfort. So she was brought into the hospital, and while there, she was determined to have essentially a pulmonary edema, which is an increase in the amount of fluids that was present in her lung. Additionally, what was determined was that she had not only the increase in the breathing and abnormality, but she had a very harsh murmur in the heart itself that was consistent with abnormal aortic valve function. And that's one of the major heart valves that allows blood to escape the heart. So the thickening and stenosis of that valve caused back pressure in the heart, and that's what caused her to have progressive heart failure and pulmonary edema. So consults were then placed for cardiology, and also for the interventional cardiology program, as well as cardiac surgery, in order to determine whether she was a candidate for what's known as a Tavr, in which the...
Sorry, what's that word?
Oh, it's capital T, capital A, capital V, capital R, Tavr. And a Tavr is when the interventional cardiologist, with backup of the cardiac surgeon, comes through the groin with a catheter, goes backwards up to the heart, and essentially attempts to do valve in valve. So rather than the old-fashioned way of splitting the chest open and opening the heart to cut out the aortic valve, in patients who are elderly or frail, it's a more elegant way of being able to replace the valve from essentially the inside. And they were attempting to work her up for that. Now, when she was admitted, the patient had requested to be a full code. And of course, she was being worked up during the first period of her hospitalization for evaluation to see whether she would qualify for the Tavr.
Okay. And how many days was she in?
Ms. Walls was at Mount Carmel West for 7 days, from November 12th through November 19th.
Doctor, please advise us of the course of her hospitalization.
So in regards to the course of the hospitalization, as said, initially because she had the problems with the breathing, they were concerned in treating her for congestive heart failure. Unfortunately, it was not an easy treatment because of the valvular problem. So as a result of that, then they decided that they had planned to do a cardiac catheterization on the patient to work the patient up. And in fact, she had an echocardiogram as part of the workup. That was on November the 13th, which showed that her left ventricular ejection was at 40 to 45%. And then she underwent heart catheterization the following day on November the 15th. And what they determined, they did in fact determine she had a bad heart valve, but she had a high-grade stenosis, a blockage in the right coronary artery. So she underwent what is known in medicine as a percutaneous coronary intervention, capital P, capital C, capital I, in which the cardiology puts a stent in the artery to open it up. And that was initially successful, but unfortunately on the next day, they noted that where the cardiologist had gone into her groin, she had a significant hematoma, or accumulation of blood. Now, when you put a stent into a patient, you have to put the patient on blood thinners, because otherwise the stent itself will clot off, and the patient usually has to be on blood thinners initially intravenously and then orally for approximately a year. The one risk of that is because you're cutting into the artery and the veins of the groin, you can result in bleeding, especially if the plug that is put in there bleeds. So she did experience a hematoma, and there was then attempts to address that, but unfortunately she required intubation, and that then occurred on November the 16th, where she was then stabilized, and they were concerned, although for a pseudoaneurysm, which is a weakening of the wall, but that was ruled out. And then eventually on that same 16th, she required dialysis.
Thank you. What progression of her problems were experienced for the next few days?
So unfortunately for Ms. Walls, her condition did continue to deteriorate. She, obviously, given all that had happened, she was not a candidate for the Tavr valve, and eventually there was a discussion made to change her code status. So she was eventually converted to a DNR CCA for the comfort care if there in fact was an arrest. And then in the early morning hours of the November 19th day, it appeared a decision was made at that point to progress to a terminal extubation.
Thank you. At that time, do you believe that the is it your opinion that the palliative extubation was appropriate?
Certainly, Mrs. Walls had a very complicated medical history. She was at high risk for continuation of medical care. The presence of her severe aortic stenosis certainly would have been a constant threat to life. And at some point, had she survived the initial bleeding episode in her leg and the placement of the stent, she would have required either the Tavr procedure or alternatively the open heart surgery in an attempt to change the valve if she would have had any quality of life moving forward. So any discussion with the patient or the next of kin would have had to weigh the risks and benefits of that moving forward. Again, certainly given that at that point she had at least been stable up to the point of the hematoma forming and the subsequent, it certainly could have also been justified to continue supporting her to see whether or not her underlying organ function would have stabilized.
Thank you. Have you reviewed the pain scoring for Mrs. Walls?
Yes, I did review the pain score.
May I approach and share with you pain scoring, which is found in the record at 560 to 562.
Thank you.
What level of control, if any, was being achieved of her pain and discomfort?
So from the time of admission on November 12th up through November 15th, she had either a 0 pain score or no indication of the pain score. On or around the 15th, when she went for the procedure, she then did have a documentation of variable increase in pain scores that were documented by the nursing staff. I saw entries of 8 and 10 included. And then it appeared that that was able to be brought under control with the orders that were placed standard in her chart, because by the 16th, it appeared that there had been reasonable control of her pain moving forward over the next couple of days, with just intermittent reports of pain up until the time that it was decided to progress to palliative extubation.
Did you take note of any other scales or scores relating to her person and appearance and or affect?
Yes, my recollection of her chart is that the nurses did document the Richmond agitation scale in her record, so there were other techniques and scoring scales that were utilized by the nurses during her hospitalization.
At the point of extubation, would the 1,000 micrograms of fentanyl and 10 milligrams of midazolam noted in your report have been an appropriate dose?
No, in my professional opinion, given Ms. Wall's underlying cardiopulmonary status, as well as her relatively advanced age, the decision to administer 1,000 micrograms of fentanyl combined with the administration of the Versed, in this case 10 milligrams, would appear to be excessive.
Is there any legitimate medical reason for this dosing?
No, in my professional opinion, having reviewed Ms. Wall's medical record, and again, knowing that her underlying cardiac status had not been completely addressed during this admission, I would see no justification medically to administer these medications, the fentanyl and Versed, at these elevated doses, even if the decision to proceed with palliative care and withdrawal is justified. But these particular medications are in excess of what Ms. Walls would have required.
What purpose could this dosing serve at this level?
So there's no medical justification for fentanyl at 1,000 mics or the Versed at 10 milligrams. So I am forced to conclude that the only purpose of these medications administered at these dosage would be to blunt Mrs. Wall's ability to breathe and thus impair her ability to support her ventilation or to respond to drops in oxygen or elevations in carbon dioxide, which would then rapidly accelerate her demise and lead to her death based on both the pulmonary but also cardiac decompensation that would occur in that situation.
Thank you. Is it, in your opinion, does the doctrine of double effect have application in this case?
No. Given the review of Ms. Wall's medical records and her progression throughout the hospitalization, certainly the end-of-life intervention here does not support or justify the doctrine of double effect. As mentioned, she really did not have consistently elevated pain scores, particularly at the end of life. She also, other than the underlying cardiopulmonary dysfunction, she did not appear to have any terminal cancer that could have caused significant pain or dysfunction. So again, I believe that the doctrine of double effect is not applicable because there was no attempt at moderation in the dosing, nor was there any proportional administration of the fentanyl and Versed that in this case was more likely than not to lead to her death as opposed to simply treating her pain or suffering.
In your opinion, did the dosing of the fentanyl and Versed cause her death?
Yes, in my professional opinion, within a reasonable degree of medical certainty, the decision to administer 1,000 mics of fentanyl in addition to the 10 milligrams of the Versed did cause and or contribute to her death by means of suppression of her respiratory system that then led to cardiac standstill and her ultimate death.
Thank you. What actions or lack of action by Dr. Husel speak to his intent in this matter?
So in this particular case, once again, there did not appear to be the involvement or integration of all the treatment teams that had been providing care for her. Clearly the medical record details very careful evaluation by cardiology, by interventional cardiology, by cardiac surgery for the workup of this potential valve surgery. I could find no record that they were involved in the ultimate decision-making to determine she was terminal and withdraw. Again, there was an absence of input from the palliative care service as to what options she might have regarding end of life, whether that be transition to home hospice or potentially even to an inpatient hospital to allow natural death to occur. And then in terms of a proactive manner, the decision to administer fentanyl and Versed at these doses in the evening hours at around the time of the terminal extubation would imply the intent to impair the patient's ability to breathe effectively, which, given her underlying cardiac frailty and the severe aortic stenosis, it would be known that that would rapidly result in the patient's death. There would be no way that a patient who has critical aortic stenosis could tolerate significant acidosis or an impairment in oxygenation for more than a brief period of time, and that's what occurred in this case.
Thank you. I'm turning now to the matter involving Melissa Pennix. Doctor, did you prepare a report on the death of Melissa Pennix?
Yes, ma'am, I did.
And did you review her medical records?
Yes,
Prepare that report.
Yes, I reviewed Melissa A. Pennix, spelled P-E-N-I-X, his medical record prior to initiating both or writing both the first and then the subsequent individual report.
Okay, thank you. At the top of the beginning page of your report, there's a history and physical. Can you talk a little bit about her overall condition and presenting issues at the hospital?
Correct. So it was well known to Mrs. Pennix's treatment team that she had underlying coronary artery disease. In fact, the medical record reflects she was at advanced age, 82, and she had multiple cardiac stents. As a result of having those stents placed inside the heart itself, in those blood vessels, as was mentioned earlier, she needed to have blood thinners for a prolonged period of time so that clots wouldn't form inside the stents. And the standard treatment was low-dose aspirin and the antiplatelet medication known as Plavix. Now, additionally, 2 months prior to this hospitalization, in September of 2018, she had developed an irregular heartbeat known as atrial fibrillation, in which the upper part of the heart, the atria, begin to quiver. When that occurs, blood can essentially congeal within the atria, and it predisposes the patient to stroke, because if those blood clots in the left atrium break loose, they'll go through the pumping chamber of the heart, the left ventricle, out the aortic valve, and they can go straight up to the head. So her doctors had added a third blood thinner, Eliquis, to the patient's regimen. The problem for Ms. Pennix is now being on 3 anticoagulants, there was an increased chance that the patient could bleed, and in fact, that's what appeared to happen. She came in with a complaint of worsening shortness of breath, and also particularly when she exerted herself. And there was also concern that she had been spitting up small amounts of blood that likely were related to the fact that there was abnormality in the lung. And you can see, if you scroll down here under admission diagnosis, it listed that there was a pneumonia, that she had both acute and chronic heart failure, and where I've written number 3, report of hemoptysis in the setting of anticoagulation, that infers the spitting up of blood. That often is the secretions coming from the lung. And then there was concern that she had a candida infection inside the esophagus, the previously discussed atrial fibrillation, and then some chronic medical problems. So the plan was to start her on antibiotic therapy, to obtain a gastroenterology consult to evaluate, to withdraw or take her off those blood thinners, particularly the Eliquis, to see if that would control the bleeding. And I believe she was initially also, besides the antibiotics that I discussed on page 2 of the report, that was prescribed, the aztreonam and vancomycin, she was given some injectable forms of steroid to try to control any inflammation within the lung itself. And she remained in the step-down unit until November the 19th.
Thank you. What happened then?
So on the 19th, her condition began to deteriorate, and it was ultimately determined that she would require intubation if she did not benefit from or tolerate non-invasive modes of ventilation. So in essence, various face masks were applied to her face, and they tried positive pressure ventilation prior to putting a breathing tube in. And as is listed on page 2 of the report, they attempted what's called AIR, AIR/VO, or BiPAP, which is bi-level positive airway pressure. It almost looks like when a jet fighter has that mask strapped to her or his face, and you're trying to not only blow oxygen, but pressure into the lung in order to avoid the patient having to be intubated. They did send specimens from her lung, which is where they describe what's known as a biofire, and they didn't determine any specific cause of the deterioration. So they transferred her to the ICU, and it was decided that she would be intubated and put on the ventilator to support her. Additionally, because she had not been, or she had required the face mask, clearly you can't eat when you're on the face mask, so there was also some nutritional concerns. And of course, they had, along the way, also consulted cardiology to evaluate her underlying cardiac status.
Thank you. Did you review the medication administration record and pain scoring for this patient?
I did, yes, ma'am.
May I present? Pain scoring.
So early in her admission, she did have complaints of pain. That was noted by the nursing staff on November the 15th into the 16th. Then it appeared that her pain began to be better controlled, and on the 17th and 18th, her pain score essentially was brought to 0. On the 19th, she had one entry shortly after midnight with a pain score of 2, but then for the remainder of the 19th until the late evening, she was a 0. At around 9:46 p.m., she had one entry of a pain score of 5, and then again, the remainder of the pain scores thereafter were none, or on the morning of November 20th, there was an entry made by nurse Marcy Zent that the pain score was not done because the patient was severely lethargic. And then thereafter, the pain score remained 0 until 5:50 in the afternoon, when there was one entry of 9, but then thereafter, the remainder of the entries were 0 up until 10:48 in the evening when the last pain score was done, and that, again, included a pain score of 8. And it appears here that the initial pain scores that were documented, unlike some of the other patients I've discussed, were what was described as a verbal intensity score. So early in her admission, she did not have a breathing tube, so the nurse could ask her what her pain score was. And then later, once she required the subsequent support, they obviously couldn't ask her, and they had to modify the pain score.
Thank you. And for the record, the pain scoring is 472 to 474. The MAR is 708 to 748. Doctor, could you please review the medication administration record in this matter and advise us of the opioid or other narcotic load or orders that were being administered to Ms. Pennix?
looking at Ms. Pennix's MARS, I see the first entry for an opiate is indicated, entered on November the 16th at 9:30 in the morning, where there was an entry for the continuous release form of morphine, and it was administered at low dose, 15 milligrams per tablet. And that was then documented, and again, related to what was identified as a pain score of 7, and she verbalized that the pain was identified as being back pain. Then it appears that the next entry was that evening of November 16th, where she had been prescribed the morphine CR, or continuous release, 15 milligram tablet, also known as MS Cotton. And here she was administered the medication, again, for a pain score of 8, although there was no location of pain. Then the next entry was on the following day, where on the morning of November 17th, she once again received morphine CR 15 milligrams for a pain score. At this point, she identified a pain score here, a verbal pain score. It says the pain score was 0, but it appears that the morphine was in fact ultimately administered to the patient. And then the next entry that we have is on the evening of the 17th, where she received her standard dose of morphine CR 15 milligrams. Again, in this particular case, at 2100 hours or 9 p.m., it looks like there was not a specific attribution of the pain score. In fact, the pain score was 0 at the point. And yet on the following page, it says pain relief with medication, which was somewhat incongruous that she didn't have pain, but yet it was relieved. Then the next entry was on the 18th at 9:37 in the morning. Again, it was morphine CR 15 milligrams, so no dose escalation. Her pain score at that point was described as a 0. Later that night that morning, there was confirmation. Her pain score was a 0. She was described as awake and alert. Her pain was described at that point as acceptable, and she had achieved adequate pain relief. And then the next entry regarding morphine CR was on the early morning of November 19th at 27 minutes after midnight. And in here, what was entered was that the medication was not given, and there's actually typed in to the record already compromised respiratory status. So the nurse, in this case, it appears to be Robert Kopp, K-O-P-P, did not administer the medication, which was certainly appropriate given, as he said, that she was showing signs of respiratory compromise. And then the next morning, on November 19th at 8:20 in the morning, there was, again, another entry for morphine here. This was for the 15 milligram. Her pain score was 0, and at least there's an action detail by nurse Hannah Huckleberry at 08:22, inferring that the morphine was at least pulled from the system. And then on the next page at 9:02, the same nurse indicated that there was acceptable pain control and that the patient was sleepy but easy to arouse. And I think that may summarize all the entries. Oh, I'm sorry, there was one more here, and that was on the evening of November 19th at 9:46. Again, there was a pain score assigned using the COP protocol of 5, and it was indicated that the nurse, in this case Corey Fleming, drew or pulled out of the system the morphine, and then on the subsequent page indicates at 2246 that the medication was given and that it appeared to have relieved the patient's pain, and the patient had an acceptable pain level and was sleeping. And then on the following morning, there was an entry on November 20th at 9 a.m. Regarding the morphine, and here Nurse Marcy Zent says that no administration of the medication was given because the patient was lethargic. And then the next description of any form of narcotic was on November 20th at essentially the initial entry was at 5:50 in the evening, and then it was charted at 7:58, and it describes the administration of Dilaudid 1 milligram to the patient, ordered by Dr. Gandhi, Gandhi, and there was a narrative addition there by the nurse saying that Miss Pennix had experienced severe pain, and below that was a description of the patient receiving Haldol, which is an anti-agitation or antipsychotic medication, and she received 2.5 milligrams of Haldol secondary to agitation. And then shortly thereafter, 9 minutes later, at 6:05 p.m., the patient received, or is this a follow-up? This may be the follow-up to the Dilaudid entry that was given earlier, where it describes that the patient is sleeping. And then...
Your Honor, this whole time he's been reading, I
agree.
failed to see where we're answering a question.
Let's ask a question there, Counselor.
Thank you. Doctor, can we address our attention to the time of the intubation in this matter and what medications were used at the intubation?
Yes, so on page 11 of my report, it indicates that the patient was intubated by Dr. Douglas Closer, Closser, and the procedure occurred at approximately 8:11 in the p.m., and it was described as an emergency intubation. The patient received 100 milligrams of ketamine, as well as 2 milligrams of Versed.
Thank you. At some point, did this case progress to a code status change?
Yes, at some point, the patient did progress to a code status change. Again, the patient had other interventions, including the placement of an arterial line for blood pressure monitoring, as well as other medications being administered. But then we see that there was a discussion about changing the code status to DNR comfort care.
Thank you. Do you feel, or is it your opinion that Mrs. Pennix had any survivability reserve?
Yes, within a reasonable degree of medical medical certainty, given her presenting symptoms that this was related to the blood thinners that had been administered to her because of the stents she had placed and the fact that she had a pneumonia in her lungs that required treatment, certainly she had not reached the point of terminal status. Also, she had just been intubated with the breathing tube placed. And so in terms of support, there really had not been ample time to determine whether or not the addition of the breathing tube, but more importantly, the addition of the ventilator could successfully support her lungs and give the antibiotics a chance to correct the infection and the other elements of her treatment to correct the underlying metabolic problems.
Did this patient have paralytics administered?
Yes, the patient received paralytics, but apparently not for the intubation. Subsequent to the intubation, the patient was ordered 2 separate paralytics. The first is a drug called Nimbex, capital N-I-M-B-E-X, which is, again, it's a skeletal muscle relaxant, and that was ordered on an infusion, and for the patient to receive 3 micrograms per kilo per minute, and to be increased, according to the order, by 0.5 micrograms per kilo per minute every 15 minutes until adequate paralysis was achieved. And the patient was also ordered a bolus dose of vecuronium, which is a paralytic from another family. So they're both muscle relaxants. The first, the Nimbex, is essentially a benzyl isoquinolone, and then the vecuronium is in the family of steroids. So those are 2 separate drug categories, and you usually don't want to mix them, because if you do, you can dramatically prolong the period of muscle paralysis.
Thank you. And at what time did this patient proceed to extubation?
So the patient proceeded to extubation. There had also been an order to increase the Nimbex that was listed on the bottom of page 16 of my report. And then one sees the entries for the medication in the medical record. Let me just find the entries here. Again, I'm just going to refer to the MARS to get the specific timing. So there was an order placed at 10:48 for 2,000 micrograms of fentanyl by IV push, and then 1 minute later at 22:49, there was an order for 10 milligrams of Versed to be administered.
Was that, who ordered that?
Those 2 orders were placed by Dr. Husel.
Does the administration record show that they were administered?
Yes, it indicates that those orders were followed by Nurse Wesley Black, B-L-A-C-K, and that the administration or action details occurred within a minute of the order being placed and occurred at 10:49.
In your opinion,
It's getting late. Do you have a lot more?
I can wrap this up by 5, I think.
Okay.
I know we're coming, you know.
We got some people giving me this over here.
Oh, we can, I mean, whatever you want.
You guys need to stop? Yeah, I see one.
Judge, we need to approach before we break for the day.
Okay.
Needs to be here. We may.
Let me have a sidebar, and then we'll get you guys to get to you, okay? David?
Okay.
Yeah. Unless he goes out.